that you want a perfect incision should be there. It should not only be perfect, it should be ergonomic. The incision length, not the width, should be at least 1.25. So you can take a caliper, mark it out, and mark 1.25 or 1.5 on the cornea. So then make a groove at the limbus, then stabilize the globe, and go forward and dip in at the point that you've made. So you're 100% sure every time that you do an incision, you'll get a perfect incision. You want the incision to be not shorter than 1 millimeter, not longer than 1.5. So mark out 1.25. It's very simple. Anybody can do that. So you want good endothelial support, do the soft shell technique. Put in a high viscosity viscoelastic, and under that put HPMC on the surface of the lens capsule. So the best CCC comes if you keep the tearing edge flat. If you flatten it, you'll get the best results. So don't let it bunch up. Keep it absolutely flat when you do the rexus. So that's very, very important. Most of us let the tearing edge bunch up, and that completely messes up your rexus. Not only that, you want the rexus to be of a perfect size. All you need to do on a slightly dry cornea, take a ring marker, 5 mm marker, you can mark it. Of course, if you have the Callisto or the Varian, you can do the marking, but believe me, once you mark it on this microscope, for about a couple of minutes, the marking is still visible even after you put HPMC. So now this is what I told you. Keep the tearing edge flat. Don't let it bunch up. Now you can follow the mark that you made on the cornea and make a perfectly sized, perfectly centered rexus, which is quite important to have perfect ELP as well as avoid any rotation that could occur early post-op or late post-op by contraction of the capsule. So this is very simple. Any one of us can do that. So that gives you a perfect incision, a perfect rexus. A perfect hydro is important because you want to be able to rotate and you want to have minimal amount of cortex left. You want a good hydro, please shallow the AC before hydro. If the AC is overfilled, then the fluid will not go in. There's no space. Shallow the AC, go in, lift up the rexus margin, free of the cortex, and then inject in that exact plane. Don't inject into the cortical mass. That's what we most often do. Once you do that, you've done a perfect cortical cleaving hydrodissection, which makes your cortex removal in the end very easy. 90% of the time, 9 out of 10, you will find that everything comes out. You don't even have to do an IA. So we've gone to good hydrodissection. What will it tell you? So let out viscoelastic, go under, lift it up. Don't disturb the cortex. The cortex is completely undisturbed. Then you inject in that particular plane. You'll get a perfect hydrodissection. Decompress. Hydrodissect inferiorly, decompress superiorly. So even if you're left with cortical remnant, it will come out very easily with an IA in a matter of seconds. You don't have to go around fishing around. So perfect hydro not only helps you rotate, but also completely reduce the amount of cortex that you left out. How do you get the perfect chop? Very simple again. So what you should do, step 1, clear the rexus area of all epinucleus and cortex. That's important. At the upper 1/3 of the rexus area, make a 2 mm punch with your phaco. Now they take the chopper. Place the chopper right in front. Absolutely centered in front. Phaco deep in, hold with vacuum, dig in, move both instruments towards each other with a short burst of phaco and separate. The chop occurs like magic with no effort whatsoever, even in a hard cataract, as I will show you. This is the firm cataract. I would say a grade 2 to grade 3, nothing great. Getting a decent chop here is quite a bit easy. Hold, separate, and emulsify. Try chopping into smaller bits as you go on. So make a 2 mm punch on top. Take the chopper right opposite to it. Bury deep in and separate where you are into the middle of the nucleus, both in the X, Y, and the Z axis. This is important. So your phaco holes into the nucleus, not into the epinucleus, because you've removed. So here we have a really hard cataract. I've done all of this. Now, go in. Now we are in 2.5 millimeters into the lens. Hold it, do a small burst of phaco, and even that hard cataract will crack with minimal effort. Separate down right to the base. With the same hold, you can do the second chop. If it loosens, go back, do a small burst of phaco, hold. It's important that the piece is held very, very well by vacuum before you attempt to separate the pieces. Once you've done that, take out all loose pieces. Don't let any loose pieces hang around there. There's no hurry to do anything at all. Take your time, separate the pieces, loosen them. Don't traumatize the zonules in a hard cataract. Make sure that all the cortical attachments are completely broken up before yanking the piece out of the bag. Trying to pull the piece out of the bag when the cortical remnants are still attached at the bottom will put stress on the zonules and cause a lot of problem. So when you do this, you will get a perfect chop 9 times out of 10 or 10 times out of 10. It is just using basic physics knowledge and holding it. So you've done the perfect incision, the perfect rhexis, perfect hydro, done the perfect chop. So you should get the perfect results also. So that's it. Any questions?
Watching you do phaco for about 20 years, and as you age, it's getting better. How is it, sir?
No, unless I believe in one thing. The moment you stop plateauing, stop practicing.
Stop what?
Practicing.
Practicing.
There's no room to plateau. If you go back and look at your 1-year-old video and you feel satisfied, give up your practice.
You had to keep improving.
If your 1-year-old video makes you feel ashamed, then you're ready to keep going. Your 3-month video tells you that you could do better, then you're on course. So don't go by age.
Arul, one more thing. You had an unusual phaco tip, box tip.
Okay.
And also one more question. For the really hard ones, are you using the longer choppers?
Yes, those choppers are designed by me. They have a special angulation. The tips are my design. They are actually patented. We're trying to talk to some of the international companies to take it up. This is a pentagon shape. It's not square, it's a pentagon. It's got a completely different architecture internally and externally, which makes the holding very efficient as well as emulsification. The difference in the EPT between the standard tips of even the standard companies is about 30 to 40% lesser EPT. We have proven that. We've done enough studies. So that's something we're still in the marketing stage. How much phaco? Vacuum. Okay, that will depend entirely on the size of your tip and the ability of your machine. So to get a decent chop in a hard cataract, you should be between 350 to 650. If you're using a narrower bore, you can go higher vacuum. If you're using a wider bore, then keep the vacuum down. Because the higher the bore, the vacuum is more efficient. Smaller the bore, the vacuum is less efficient. So that's how you go. So it depends on the safety margin of your machine and the tip that you're using.
Next one is, the question is like in certain softer cataracts or diabetic cataracts where it's sticky, does this technique, if you have difficulties in chopping, what is an alternative technique in these cataracts?
We'll come to that. Now, that is where in different grades of cataract, you have to have different levels of flow rate and vacuum. So then you'll have to have, see what happens when you have a soft cataract, when you have a high flow rate of 40 and a vacuum of 400, before you bury, the whole thing is sucked out and you have nothing to hold, you're bowling it out. So then you'll have to have low flow and low vacuum. So I don't feel comfortable setting multiple settings on my machine saying go to low flow, low vacuum. So both flow, vacuum, and energy are linear on my machine. So when I go down to position 2, though my flow rate could be 40, at the top of position 2, my flow rate is only 20. If I get occlusion at 20, my vacuum starts to build up. My vacuum will not go to 600, though my preset vacuum is 600. It will only go to about 100, 150 because I'm at the top level. Agreed? So you'll have to look at what you're doing, and when you get enough hole, chop immediately. So by titrating your foot pedal, the question asked often is, how can you do that? It's not possible. No. We all drive a car. You want to go slow, you could put the accelerator down a little bit. You want to inch forward in traffic. You want to stop, you stop, go down, come up. It's the same thing. There's no difference between the accelerator and your foot pedal on your phaco, as long as you understand where you are and what you're doing. So I set everything linear, so I have no difficulty whether it's a soft cataract or hard cataract. I'm not a fan of trying to have different settings, 4 different settings, then tell my staff nurse or my theater boy, go to setting 1, this setting 2. I don't think that...
One more small comment. So one tip which I learned in soft cataract is, we have to do 2 hydros. If you separate the nucleus from the epinucleus and do a 2-step hydro, it becomes very easy. So do a hydro dissection, do a hydro delineation. You phaco the inner part, whatever you want, bowl it, whatever. The rest you can aspirate. When we try to do the standard chop, it's more difficult. You need a very high level of skill. It's not under control. So do 2 hydros for them. It becomes so simple.
That was a brilliant answer.
Be you planning different in a case where you have a central disc, also a leathery cataract. Leathery cataract and also a central attached disc.
See, the disc is not so difficult to remove. The peripheral leathery part is always sticky. It's like a nougat chocolate. You can't chop it, you can't separate it. So in those kind of situations, take out the central core. It'll come out like a kernel. Once that comes off, it's a little bit easier. You have more room to maneuver, to hold the leathery part, and there you'll have to really stretch a bit, keep on stretching till it tears to the bottom. So if you have a central hard core and a leathery covering epinucleus, if wherever possible, take out the kernel. It makes your job much easier. So we'll go on to the next one. Now, you've done everything perfect.
So how to reduce the surgical induced astigmatism?
How do you?
Surgically induced astigmatism.
How do you prevent induced astigmatism? Exactly what I meant. I'm sorry, I should have been more elaborative. If your incision is limbal, if it is temporal, and if it is going to be about 1.5 millimeters in length, you are not going to induce any astigmatism. Whatever induces somewhere in the region of 0.12 diopters. So don't worry. It is when you move the incision away from the temporal side to either inferior, which you never do, but you go superior, you start inducing more astigmatism. Second mistake, you're not limbal, you go completely corneal. The more anterior you go, you will induce astigmatism. So stay temporal, stay limbal, and a length of around 1.5 millimeters, you will never induce any astigmatism, provided you have not burnt the wound. Huh?
Width of the incision.
Width of the incision, today most of us are at 2.4, but believe me, up to 2.8, you don't induce any astigmatism.
You were using in last case, can it be used in all machines? Or
Yes,
you were
yes,
using
yes.
all
It has been validated on about 2 dozen machines.
What's the name? What's the name and where can
No,
I
it's not
got
available
it?
for sale.
Eh?
It is not available for sale because it is patented. I've given the design to an American company. They have patented it. They are in the process of marketing it. So it is not yet for sale.
It is something new. It will soon come to the market.
It has not marketed.
No, no,
No,
no.
nowhere in the world. I'm using it.
In future we can get that. In future
Yes,
we can get
100%,
that.
100%.
So what will be the name of that
It will be probably called pentagon tip.
pentagon?
Pentagon tip, yeah. So we've done everything right, but you have an unhappy patient. So we will have Dr. Atik who's going to take us to analyzing what do you do when you have an